Welcome to the clinical scenarios, and this is your case number 28. A 3-year girl is brought to the physician for the intermittent eye crossing. Now this is typically a case that occurs, whatever problem they have, they usually go first to the physician. Like physician is there always first doctor, and then they are being referred or they are being told that they have to visit a ophthalmologist. Okay, the parents say that left eye is intermittently turned in during the first few months of life. See, she had already intermittently turned in eye in the first few months of life, and now she is 3 years and still not they have visited the ophthalmologist. The symptoms have returned in the past month and now they are occurring again, especially during the dim light. Why? Because they are saying they are around the bedtime. So I can say that they are appearing in the dim light. She has no headache or pain. The girl was full term, no medical conditions, and she has met all the developmental milestones. So this is a good thing that they have told us all the negative history, because whenever we are solving a case related to a neonate, an infant, toddler, child, we get to know, we require certain history, that was there any intervention at the time of birth, anything significant there in the ANC history, any radiation exposure to the mother, or any drug history, and history of fever with rashes, was this baby full term or not, milestones normal or not, or baby has some kind of significant examination or history at the time of birth. So we do require all these things. Now vitals, they are saying that the vitals are also normal. Examination is showing an important thing. Examination shows asymmetrical corneal light reflection. What is this? Asymmetrical reflex. That is Hirschberg corneal reflex. Hirschberg corneal reflex test. So if you are doing this Hirschberg corneal reflex test, so that is asymmetrical, and also previously we had a history of eye moving in. So most probably they are having giving a history of EZO, that is convergent squint. Now when the right eye is covered, left eye is going midline. So this problem was in left eye. Left eye was having the squint, and it is, that means a manifest squint. They are covering the other eye and they are doing the test. So they say that when they cover the other eye, that is normal eye, and now left eye is actually forced to fixate. So it is taking the central fixation, it is moving. So because it is moving, that means it was not in the midline, it was moved, it was deviated. So it has moved to the midline. Vision is normal here. The rest of the examination is also normal. So they are asking the most appropriate next step in the management of this patient. What should be the next step? They are not asking you the best thing that you can do. They are just asking what should be the next step in the management. And if you remember, I have given you always that you have to give the treatment also in cases of the squint in a order wise. So if they have already given you first step, go to the second, then third, fourth, somewhat like this. Okay, now this baby is having some problem. This baby is having some problem, and there is a history of the deviation of the left eye intermittently towards the inner aspect. So suppose this is your right eye and this is your left eye. A right eye there is no problem, so this is normal here, but they say that intermittently left eye is turned in like this. So we have the esotropia. We have esotropia, and because the eye is moving in, so you will get this Hirschberg corneal reflex test also to be asymmetric. Okay, when you see the corneal reflexes, then obviously both the reflexes will not be evident in the center because one of the cornea has moved in. So pupillary reflex will be shifted, and how do you diagnose it? So we will revise that also. Suppose this is your cornea and this is your pupil, like this. So normally the reflex should be present in the center. So if it is present in the center, I will say 0 degree, no squint is present. This is your 0 degree or no squint. If I have the reflex somewhere on the pupillary border, then I will say that this patient is having the 15 degree squint. If this patient is having this reflex on the limbus, then I will say at the limbus it will be 45 degree. If it is in the center here, so in the center it will be 45 minus 15, this equals to 30 degree squint. So we have 30 degree, 15 degree, 0 degree and 45 degree. So they are saying that it is asymmetrical, both the eyes are not having the central reflex. Then they are also talking about the cover test. So what kind of cover test it is? They are saying that suppose this is the right eye here, normal one, and this is the left eye. They say that when we are covering the right eye, so we are covering the right eye here with the help of a occluder. So let's see how we are doing it. We are covering this right eye with the help of a occluder. So what is going to take place? So when I cover this right eye with the help of a occluder, okay, this test is called as your direct cover test. Then this test is called as a direct cover test. So when we have occluded the normal eye, now I am forcing the squint eye, forcing the squint eye to fixate. So I am forcing the squint eye to fixate. So if it is deviated in, now it will be moving outward. Recovery movement. Recovery movement is outward. It is always in the opposite directions and it will be coming in the center. This will be its final position. Yes. So look at the question now, what they are telling you. They are saying that there is a previous history of intermittent eye crossing in the first few months. It was in the left eye and especially during the bedtime. You know, these squints got aggravated when the patient is working for long hours or the dim light or the near work, and otherwise there is no headache, there is no pain, baby is full term, no medical condition, no developmental delay, vitals are also normal. Visual acuity, they are seeing, visual screening is also normal, examination is also normal here. So what should be the next step in the management of this patient? So we have done workup till now. Now let's see what are the options they are trying to give us. The first thing they are saying is the brain MRI, measurement of intraocular pressure, patch on the right eye. Patch on the right eye means normal eye, and then they are saying watchful waiting. Now let's discuss the option number 1, brain MRI. So brain MRI is not the useful next step. They are just saying next step. So if the baby is coming to me having some kind of history of deviation, okay, and I'm seeing a asymmetric corneal reflex, then I will first try to do the basic things and try to find out the cause of the squint. I will not go for the brain MRI directly. So this is not the most appropriate next step. First you have to see, analyze the patient. If you find that there is certain thing which requires brain MRI, only then you are going to do. Suppose I am getting some leukocoria. Like if you remember in the previous case there was a retinoblastoma that will lead to the convergent squint. So if I get the evidence that this squint is due to retinoblastoma, I'll try to do the ultrasound, I'll try to do the MRI to find the necessary details. So obviously this is not my next step. Then they say measurement of intraocular pressure. So intraocular pressure is actually measured in cases of congenital glaucoma. So if I am thinking on the lines of congenital glaucoma, only then I need to measure the intraocular pressure. Congenital glaucoma less than 3 years of age, that is actually leading to the buphthalmos. That is actually leading to the buphthalmos. So buphthalmos, there will be raised intraocular pressure at the time of birth. That is leading to stretching of the eyeball. So you have the raised intraocular pressure leading to large size eyeball. So these babies will be presenting with typical below poverty line, that is BPL card. There will be blepharospasm, photophobia, lacrimation, eye rubbing, corneal edema, we have frosted glass appearance, we have megalocornea, we have blue sclera. So there are so many things. Here the baby does not have any of that. So this is also not the measurement of intraocular pressure. Now third is patching on the right eye. So we'll come back to it. And D is watchful waiting. Can I wait here? If this patient is having the squint, okay, and you are waiting, what can happen? This can lead to even worsening of that eye. There can be more and more amblyopia. There will be more and more amblyopia, and after certain periods it becomes refractory. So after certain period it becomes refractory. It is not treatable after like 5 to 6 years of age. After 5 to 6 years of age, the amblyopia becomes refractory. So even if you are treating it, there is no benefit from that. So obviously you cannot take it lightly. Squint is one condition that requires the immediate treatment there. Okay. Now if I discuss the treatment, so how to go about it? How to go about the treatment. So most probably it is a case of comitant squint, because it is not a latent squint, we can see the squint, it is a manifest squint. So you have to go in an order, and order is C, O1, O2, S and P. This is the order. So first is C. You have to do the correction of the refractive error. Do the refraction, find if there is any refractive error, and you have to correct it, because most probably the cause of amblyopia is the refractive error. Then number 2, we do the O1. O1 is your occlusion therapy. O1 is the occlusion therapy, and this is actually best for the amblyopia. This is for the best for the amblyopia. So whenever we are having a case of the comitant squint, our first and foremost priority is giving the occlusion therapy. I'll talk about it. Then let's see the O2. In O2 we give the orthoptic treatment or the orthoptic exercises, orthoptic treatment or orthoptic exercises. Then we move on to surgery. And if you have some remaining correction even after the surgery, then we go for the prisms in the glasses. Prisms in the glasses we are giving. Alright. Now, if I talk about this occlusion therapy, so which eye actually should be occluded? So, it is always the normal eye. We are occluding the normal eye. And what was normal eye in this case? It was the right eye. Left eye was showing the squint, while the normal eye was the right eye, because we want to stimulate the squint eye to see. So it is possible only when you are occluding the normal eye. So once you occlude the normal eye, we are forcing the squint eye to see. Now what will happen if you are covering this eye? Now we have a risk of even this normal eye going into amblyopia. So obviously you have to follow some order. So what is the rule of occlusion? What is the rule of occlusion? The rule of occlusion is very simple. It says x is to 1. It is x is to 1. 1 means for one day normal eye is kept open. For one day you have to keep the normal eye open, and x is the age in years. This will be equal to the number of days of occlusion. Number of days of occlusion. Now, how to comprehend this? They say that the age in years will be equal to the number of days of occlusion. So, if the baby is 1 year, then you have to occlude for 1 days, okay, and is to 1 remains constant, and 1 day you have to keep it open. So, it becomes 1 is to 1. 1 day occlusion, then 1 day open, then 1 day occlusion, then 1 day open, and so on. When the baby becomes 2 years, now it becomes 2 is to 1. So now you have increased the number of days of occlusion to 2. So 2 day occlusion, then 1 day open, 2 day occlusion, 1 day open, like this. Similarly, at 3 years you have to do 3 is to 1. Now 3 day occlusion, 1 day open, 3 day occlusion, 1 day open, 3 day occlusion, 1 day open. Then at 4 years, go with the 4 is to 1. 4 days occlusion, 1 day open, 4 days occlusion, 1 day open, 4 day occlusion, 1 day open. And finally, because you know, after 5 to 6 years it becomes refractory. So usually we give it to up to the 5 years. So at 5 years you are giving 5 is to 1. So now you are occluding the normal eye for 5 days. Keep it open for 1 day so that it does not become amblyopic, and then again occluding for the 5 days. Now it is very simple to say all these things, but it's really a hard time doing it. So what we do actually, if you remember, I always mention these things in the class. So I got to show you also. So you have to actually use like so many skills and tactics in order to get your small babies occluded, because you think yourself you don't want to wear the spectacles, you will have so much of reluctance while your eye is occluded for a second. Sometimes, you know, friends come, they occlude the eye, and then we are relucting so much. So can you think that we are occluding the eye for such a long time? So what we are doing, like here we have first prescribed the spectacles to this cute baby, and she also did not want to have the occlusion. So we have used certain bright colors and the things that she liked. So that she looks that as if she is looking pretty. When she stands in front of the mirror, she feels that she is looking attractive and pretty. Sometimes what we are doing, we are like putting certain things interesting towards this eye, so that the baby starts seeing those things which she's interested in or he is interested in. Some cartoon characters, in cases they are liking some Disney, some Doraemon, some Shinchan, so they are starting cooperating with us. So I think, you know, that way pediatrics is really a challenging branch. You know, you know the treatment, but how to give it becomes really challenging there. So if you look at the options here, So what is the correct option? The correct option to this question will be patch on the right eye, because this is the normal eye. So I want to do the occlusion therapy patching the right eye so that the left eye is forced to see. Alright. In case of any doubt, your suggestions, your feedbacks are most valuable. So you can always ping me up on my YouTube channel, my Facebook page, Facebook group. You can follow me on the Instagram and take the advantage of their daily posts there. We have daily quizzes on the Telegram. Daily we do share the motivational stuff, the academic stuff, having the interactive sessions, solving the doubts and queries of the students, and you can have a pertinent, interest in that subject, so that you do not feel like disconnected from ophthalmology, because what happens, you have to cover 19 subjects, and once you have done the subject and you are there after 10 subjects, you feel that you have lost it. And that was the sole purpose of starting this session of clinical scenarios and conducting the daily quizzes on Telegram, because I was daily getting the same message from so many students that when we were taught ophthalmology, ma'am, we could have understood everything and we were able to do the questions. Now after completing 10 subjects, we have 9 subjects in front of us, and it is like we are forgetting everything. So this was a small initiative so that we can revise daily some small topic, and you do not have that fear that you are losing those subjects that have already gone back and you do not know anything from that. So do tell me, how do you like this? What are the other videos that you want me to share, and any other way that I can help you, I'll be more than happy. Thank you, and happy ophthalmology.